body talk on the knee joint and the ankle joint. So first of all, we'll identify the type of joint it is. We'll start to look at which bones and bony structures we should be aware of, discuss the movements available at each joint, and of course what muscles cause those movements. So starting with the knee joint itself. Now the knee joint is structurally a double condylar joint. What that means is that it is comprised of two large condyles of the femur, which are two round bulbous bony structures at the distal end of the femoral shaft of the femoral head. Now it functions as a hinge joint in that there is one axis with a forward and back movement, so two directions with one axis. So structurally a double condylar joint, you can see the two condyles there, but functionally acts as a hinge joint. These two condyles articulate with two tibial plateaus of the tibia, which are relatively flat, meaning this joint is poorly fitting or has a poor level of congruency. There are ways that the body has improved its congruency, which we'll have a look at shortly. But just moving around to the front, we've got a bone that sits just in front of the femur called the patella. Now the patella is a sesamoid bone, and a sesamoid bone is a bone born within a tendon. There's a couple of other sesamoid bones found in the thumb and the big toe. Then we have the tibia, which is the major weight-bearing bone of the lower leg, and laterally to that we have the fibula, which is smaller and sort of slender, and bears much less weight than the tibia, and is predominantly there to give another surface for muscles to attach to. The tibia will articulate distally with the talus, forming the ankle joint or the talocrural joint. So the talocrural joint inferiorly, superior to that, we do have an articulation between the tibia and the fibula, but we'll focus predominantly on the tibiofemoral joint, so the meeting of the tibia and the femur. Okay, so looking at the knee joint itself, as I said, it's structurally a double condylar joint, and these two round condyles articulate with the two tibial plateaus of the tibia. Now, because these condyles are round and the tibial plateaus are flat, it's pretty poorly fit. It's a pretty poor fit. So the way in which the body gets around this is by having two small donuts or menisci on each tibial plateau. These menisci improve both the congruency but also have a proprioceptive role in that they enable people to determine joint position by having a certain sensory or what's known as mechanoreceptors, nerves that detect movement or position within them. So if these structures are injured or this joint is injured, one of the strategies to improve it and to rehab it is to improve proprioception. Okay, so there are the two menisci. We're going to look at some ligaments now. We're going to look at firstly the ACL. Now we've got these cruciate ligaments, and they're called cruciate ligaments because they form a crucifix or a cross, and they're named according to their tibial attachment. So the first ligament is called the ACL, and this attaches from the front of the tibia to just around the back of the femur. Now these cruciate ligaments are intracapsular but extrasynovial, and they become taut at the extremes of flexion and extension, but they do not impede rotation or the locking mechanism of the knee joint. Now the ACL prevents anterior or backwards displacement of the femur on the tibia when weight bearing, and in a non-weight bearing position it presents forward displacement of the tibia on the femur. The posterior cruciate ligament, on the other hand, which attaches from the posterior aspect of the tibia to we'll have a look here, just around to the anterior of the femur, essentially prevents hyperextension of the knee joint. And often you'll damage a PCL, which is not as problematic as an ACL, by someone falling on an outstretched knee, causing hyperextension. The ACL can be injured by rapid deceleration and twisting or turning on one leg, and is commonly injured in sports such as football, AFL, and netball, sports where there is sort of a 360-degree attacking or defending zone, or there is rapid accelerative and decelerative forces. So there's the ACL and the PCL. We've looked at both the medial and lateral meniscus. Now we'll look at the two collateral ligaments. So we have a medial collateral ligament and a lateral collateral ligament. Looking at the lateral collateral ligament first of all. Now this ligament would minimize or prevent what's known as genu varum, which is bow-leggedness, whereas the medial collateral ligament would prevent or minimize genu valgum, which is knock-kneedness. Okay, on to the patella now. So the patella, as I mentioned, is a sesamoid bone, and the patella is, if you like, suspended within the quadricep tendon, and its job is to act as a spacer, and by that I mean it increases the moment of the quadriceps, in that it brings the effort of the quadriceps away from the fulcrum and acts as a spacer, increasing the quadriceps leverage. Now an interesting note is that babies aren't really born with a fully formed patella. They're born with a sort of cartilaginous seed, if you will, and when the baby or the infant starts to bear weight on its legs, this will ossify that patella into a fully formed ossified patella. Okay, let's take a look at some of the muscular anatomy of the knee joint. We'll start at the anterior aspect first of all, and we have the quadriceps, which is a four-headed muscle group. All four muscles have a name indicative of their location or geography on the thigh, and all four of them extend the knee joint, with one being rectus femoris, crossing beyond the hip and being therefore a hip flexor as well. So we'll start from the lateral aspect. We have a muscle called vastus lateralis. Now vastus lateralis originates just along what's known as the intratrochanteric line, and inserts on the common insertion just on the tibial tuberosity via the patella ligament, or the patella tendon as it's sometimes known as. So the vastus lateralis does have a fascial attachment just to the iliotibial band, or the ITB, and can play a role in patella stability. Because it only crosses the knee joint, it's solely a knee extensor. Okay, moving medially, we have the largest of the quadriceps, called rectus femoris. Now this has an origin on what's known as the AIIS, the anterior inferior iliac spine. Traverses along the front of the thigh and then attaches where all the other quadriceps attach via the patella and via the patella tendon to the tibial tuberosity. Now this is a bipennate muscle in that there's a central tendon with fibers running at both sides at 45 degrees, whereas the vastus medialis and lateralis are unipennate muscles. If you like, half a feather for a unipennate and a full feather arrangement for a bipennate. So as I said, because it crosses the front of the hip, it's a hip flexor and is also a knee extensor by virtue of its attachment over the front of the knee to the tibial tuberosity. So medial to that, we have the vastus medialis, And the vastus medialis originates along the whole length of what's known as the linea aspera and the medial condyloid ridge of the femur. Attaches over the patella, of course, and to that common insertion to the tibial tuberosity. Is only a knee extensor, but because there are some oblique fibers known as vastus medialis obliquus, or VMO for short, they also can play a role in medial patellar stability. Okay, underneath the rectus femoris we have what's known as vastus intermedius, is the middle quadricep, attaches from the sort of superior aspect of the shaft of the femur and attaches over the front of the knee to that same tibial tuberosity, making it only a knee extensor. Okay, so moving to the posterior aspect of the knee joint, we've got the hamstrings, of course. Now the hamstrings are 3 muscles, and their names are biceps femoris, semimembranosus, and semitendinosus. So as you can see there, the hamstrings highlighted. Now all 3 hamstrings attach from the ischial tuberosity, and they attach to the lower leg, with the biceps femoris attaching to the fibula and the semitendinosus and semimembranosus attaching to the tibia. Now the main thing to consider with these muscles is that because they cross the back of the hip, it makes them hip extensors, and because they cross the back of the knee, they are knee flexors also. Now, I did mention at the beginning of the lecture that the knee joint functions as a hinge joint, but structurally is a double condylar joint. What we also have is an aspect of the knee called the locking mechanism. Now the locking mechanism is a mechanism designed to encourage stability of the knee, and essentially what that means is that when the knee is extending, the femur will rotate medially on the tibial plateaus. This is to align both condyles with 2 meniscus to ensure stability, and will then be in what's known as the close packed position, which is the patella femoral most stable joint, or indeed the tibial femoral's most stable position. Okay, moving to the lower leg now. So we've got a number of muscles to bear in mind. We'll start with the largest of the lower leg muscles, called gastrocnemius, meaning 2 bellies. Now this is a 2-bellied muscle which, because it crosses the knee but also crosses the ankle, it's both a knee flexor and an ankle plantar flexor. So this muscle attaches just above each medial and lateral condyle of the femur, traverses down the back of the lower leg, and attaches to the calcaneal tuberosity, or the heel bone if you like, via the Achilles tendon. So as we can see, the highlighted blue muscle, because it attaches around the back of the knee, it would be a knee flexor, and because it attaches to the heel bone, it would pull the heel up, which would in turn point the toes down, which we call plantar flexion. Okay, so underneath the gastrocnemius muscle we have another ankle muscle called the soleus. Now the soleus is only a plantar flexor. It does not cross the knee joint, as we can see there, so only acts upon the ankle and causes plantar flexion when it concentrically contracts. Okay, on the lateral aspect of the lower leg we have what's known as peroneus longus, which is a muscle which originates on the head and the upper 2/3 of the lateral surface of the fibula, which is the lateral lower leg bone, and has an insertion on the undersurface of both the medial cuneiform and the first metatarsal bones. Now this muscle causes both plantar flexion, so the pointing of the toes, but also foot eversion as well. Okay, and finally what we have is a muscle that runs at the front of the tibia, which is called tibularis anterior. Now this has an origin which is around about the upper 2/3 of the lateral surface of the tibia and inserts on the inner surface of the medial cuneiform bone and also the base of the first metatarsal, so the base of the big toe. Now its job is really to oppose the plantar flexors by causing dorsiflexion, which is the lifting up of the toes. It also causes foot inversion as well. Okay, which is sort of bringing the big toe upwards. So that's all the muscles in the ankle joint. Just to sort of summarize, the ankle joint is a very tough hinge joint. It's made from the tibia and the talus, called the talocrural joint. Has the two plantar flexors, or the two major plantar flexors, which we have the soleus and the gastrocnemius. Gastrocnemius is anatomically different to the soleus because it obviously crosses both the back of the knee and the ankle, whereas the soleus only draws the foot down in plantar flexion. Then we spoke about peroneus longus, and then finally tibularis.